All of you stay glued to your seat. We have the best of speakers here and very interesting topics in refractive surgery national symposium. And I think we will not waste time. If all of you are okay to go on to a different session starting off without a break. Incidentally, because Dr. Sri Ganesh has one other place where he has to be present, so he wants to give his talk. So it starts with presbyopia directions, but after that, it will go in its exact sequence. Thank you.
Good morning, everybody, and thank you, Dr. Chitra. So we look at the options, the presbyopia directions in refractive surgery, and because I am a consultant for Carl Zeiss Meditech, presbyopia is the holy grail of refractive surgery. So we are starting with the holy grail. So the challenge is you have a clear lens and patient expectations are high. They want to be like 20-year-olds and see for distance, intermediate and near. And the other challenge is that presbyopia is a progressive condition. There are various options available. You have corneal options, you have multifocal lenses, and you have lens options, and you have scleral options. The scleral options by and large are obsolete. In corneal procedures, you have addition, subtraction, and molding techniques. The addition are the inlays, the subtraction are different types of LASIK, and molding is CK and intracore, both of which have become obsolete, so we won't go through them. When you want to decide on how you want to treat a presbyopic patient, basically these are the options. Camera inlays, you can have, corneal inlays, you can have camera, flexiview, or raindrop. The flexiview and raindrop have kind of gone out of practice, so mainly the camera is available. LASIK procedure, you have Monovision LASIK, Monovision Smile, multifocal LASIK, like Presbymax or Supracore, and then you have laser blended vision, which is a little different. Regarding the refractive lens exchange, you can do a refractive lens exchange with a multifocal IOL, extended depth of field, or accommodative lens. And now you have presbyopic phakic IOLs also. The addition procedures are basically corneal inlays. They are intracorneal prosthetic devices, which are thin, small diameter, high nutrient and fluid permeability. They are implanted in mid to deep stroma of the non-dominant eye and improve uncorrected near vision by a modified monovision approach. The surgical procedure can either be a femtosecond laser enabled stromal pocket, or if you want to do a combined procedure, if there is some amount of ametropia and you want to correct it, then you can make a flap, and along with the ablation you can put in the inlay, or you can have both a flap and a tunnel and do a combined procedure. So like I said, the commercially available inlays, the flexiview and the Presby lens, the raindrop, are basically kind of getting obsolete. The camera is available, but the number of implants have reduced. This is the only FDA approved implant. It's a small aperture corneal inlay with a pinhole effect to increase depth of field, and it is just 5 microns thin, super thin. The 1.6 mm central annulus acts like a pinhole, and the total diameter is 3.8 millimeters. The pros and cons of corneal inlay: the pros are it is an extraocular procedure, minimally invasive, easy to perform, and reversible. Cons are it involves the visual axis, adversely affects distance vision in emetropes, and there can be epithelial ingrowth resulting in thinning and melting of the flap. Coming to the presbyopic LASIK, Presby LASIK, basically you can reshape the cornea into different zones for near, distance, and intermediate vision. Different algorithms are used to create a multifocal cornea. The multifocal transition profiles were first introduced by Vissix, but have gone out of practice now. The peripheral Presby LASIK was introduced by Nidec, and the central Presby LASIK profile by Schwind and Presbymax and the Supracore. So the multifocal transitional ablation gives a standard addition of 1.75. It's almost like giving a lower add in bifocal, but there's a lot of vertical coma, and patient satisfaction is not poor. It's gone out of practice. The peripheral Presby LASIK profile was introduced by Nidec, and mechanism is central cornea is assigned for distance vision, peripheral cornea is ablated to create a hypernegative zone, and then it can be done for myopes, hyperopes, and emetropes. The central Presby LASIK profile or what is called center near is more in practice with different companies like Schwind and Supraco, the Bosch and Lomb introducing it. A hyperpositive area is created at the center of the cornea for near vision, while the periphery provides focus for distance, and it is indicated for initial to moderate presbyopia, and you can also treat ametropia along with presbyopia. Disadvantages of a multifocal cornea is it's a temporary solution, 5 years, may need enhancements, may affect IOL calculations for cataract surgery, decreases contrast sensitivity. The center near ablations generally reduce distance vision too much, especially when the pupil constricts. So the peripheral near induced unwanted aberrations in the pupil due to overlap in the optical and transition zone can give rise to glare and halos. Coming to monovision LASIK, this is the most popular technique being used all over the world, where you correct one eye for distance and the other eye for near. And however, with a full monovision where you give a 2.5 add, there is a maximum amount of anisometropia and higher risk of side effects, and it is not accepted by patients. Only about 67% of patients accept this kind of a monovision. So more commonly a partial monovision is done, where the non-dominant eye is corrected up till 1.5 diopters, but that is again not adequate for reading. So the pros of the traditional monovision: easy to perform, similar technique as LASIK, no special software required. Cons are its poor tolerance to anisometropia, poor intermediate vision, reduces binocular acuity and stereopsis, and exact level of anisometropia that should be targeted again remains controversial, and a longer time for neuroadaptation. Coming to laser blended vision or Presbyon, this is getting more popular, and this is a procedure I had 4 years ago, and I can tell you that it works pretty well. The principles are increased depth of focus by controlled induction of spherical aberration along with a micro monovision. So the dominant eye is targeted for ametropia and the non-dominant for myopia of approximately 1.5 diopters. The ablation profiles also incorporate a precompensation factor which modify the spherical aberration. So the modified spherical aberration provides an increased depth of field without compromising contrast sensitivity and quality of vision. So if you look at spherical aberration and depth of field, the effect, if you don't have any spherical aberration, then you have a very sharp focus, but on either side of the focus it is a little blur, the image, and with some amount of spherical aberration you can see that even if you have a little bit of change in the plane, there is a circle of least confusion where it is sharpest, and even on either side it is not that blur. If you look at a simulation for 1.5 diopters of defocus at 7 millimeters, it is pretty blurry and you may not be able to read the target. But if you add spherical aberration, it becomes better. If the pupil size reduces to 4 mm also, it's a little better. You combine both of them, then it's a fairly decent image. And combined with the central neural processing, the image is quite good. And current possible depth of field increase is only 1.5 diopters. If you try to increase more by inducing more spherical aberration, the contrast reduces and you have side effects. But then you can only see with 1.5 diopters for distance and some amount of intermediate. So you combine that with a micro monovision where you make the non-dominant eye. So that is loss of contrast if you try to increase it more than 1.5. So what is done is you induce spherical aberration in both eyes to give you a depth of field of 1.5 diopters, and then you also target micro monovision of 1.5 diopters. So you can see for all distances, distance, intermediate and near, and you have a blend zone. That's why it's called laser blended vision, which is the intermediate zone where both eyes focus very well and you have a summation. So patient selection is similar to LASIK, and you can correct myopia up till 8.5 diopters and hyperopia up till 5.75 and ametropia. But these are some of the tests which are very important: ocular dominance testing, micro monovision assessment, and ideal candidates should not have any cross blurring. They should have good fusion and suppression. Then the details are entered into the CRS master, the planning software on the MEL 80 or MEL 90, and then the procedure is performed. Coming to intraocular surgery or refractive lens exchange, the natural lens is removed and replaced with a multifocal or accommodative lens. Again, multifocal lenses, there are various types, but commonly available now today are the diffractive, which can either be bifocals, trifocal, extended range of vision. The most popular ones today are the trifocal IOLs, either the LISA or the Panoptics, and they work quite well. You also have the extended depth of vision lenses, typically the Symphony, which has a proprietary HLED design, which elongates the focus in the eye, and combined with achromatic technology, which reduces chromatic aberration, it gives a good quality of vision. Accommodative IOLs are by and large obsolete. The Crystal lens, which was first introduced, the FDA approved lens, has been used, but you can see that there is not much of a accommodation which happens, so basically these are not being used much. The disadvantages of the intraocular procedure is not reversible, decreased contrast sensitivity, halo and glare. You need time for neuroadaptation. Sometimes you have to YAG them early for mild PCO, and you have to be very careful while selecting candidates. And so this wraps up the options for presbyopia and the directions for presbyopic surgery. Thank you very much for your attention.
Thank you, Dr. Sri, for a wonderful compilation of presbyopic treatments. Are there any questions for Dr. Sri Ganesh? Otherwise, for all the other talks, we'll have discussions at the end of the session. But because she has to go away, please ask.
Okay. In the patients who are going presbyopic or presby and LASIK, what will be your choice of IOL if they get cataract? Yeah. Will it be multifocal? Will it be, what about the sphericity of those lenses? It will be spherical, negative or positive?
You do not prefer multifocal lenses, and basically it's important to use a good formula. If the patient was really like to use the Barak-Truke, we have done about 3 patients right now, post-Presbyopia who developed cataract. You don't use a negative aspheric lens. You use either a plano, neutral lens, neutral aberration lens, or positive spherical aberration, and you target minus 1.5 in the to minus 1.75 in the non-dominant eye, because they are already used to this, so they are very happy after the procedure.
That's good. And secondly, what about the presbyopic phakic IOLs? What is the future you see?
I have no experience, but again, the incidence of cataract may be more, so you will have to put it in and then remove it after some time and remove the cataract. Especially older patients with phakic IOLs, probably the incidence of cataract may be more, and there are no published details on this. It's just being available right now with a few of the companies.
Thank you, Dr. Sri.
Thank you.
Corneal